Moran. She's a psychiatrist and researcher in the Division of Psychotic Disorders at McLean Hospital and Birmingham and Women's Hospital Division of Psychoepidemiology and Pharmacoeconomics. Her research focused on the risk of psychosis and mania with prescription stimulants, which was published in the New England Journal of Medicine. So I'd love to turn it over to her.
Thanks so much for the introduction. Today I'm going to be talking about stimulant treatment for adult ADHD, the evidence of benefits and harms. And this was initially presented at the American Society for Addiction Medicine, along with some other individuals, Leah Bauer, Andrea Troncalli, and with some help from Margaret Chaplin, who aren't here today. And so just a disclosure, I don't have any conflicts of interest. I do get funding from the NIH to study the risk of prescription stimulants. And the goals of today's talk is to really raise awareness of the complexity of ADHD diagnosis, understand the evidence for treatment of adult ADHD, alone and in individuals with substance use disorder, and to understand the potential harms of treating ADHD with stimulants. So why delve into this topic? There's been increases of rates of ADHD treatment nationwide. There's been a very large increase actually in the use specifically of the mixed amphetamine salts in adults with ADHD. And this is actually mostly driven by increase in telehealth and stimulant prescribing through telehealth mechanisms. ADHD disproportionately affects people with substance use disorders and comes with the tension of wanting to treat ADHD symptoms, but at the risk of developing, activating, or contributing to a stimulant use disorder. And it's also important to understand that pharmaceutical company interest has led research underlying the benefits of stimulants. So this is just a graph of going through 2013. On the y-axis, there's the number of prescriptions dispensed in, and you can see that right around COVID, there was a sharp acceleration in the prescribing of stimulants that is mostly driven by increases in amphetamine and not methylphenidate or other stimulants. So across the country, 3 to 7% of adults have ADHD, but it's actually much higher in individuals with substance use disorder. So it's up to like 10 to 21% in various studies. And ADHD has a lot of morbidity. It's associated with increased rates of unemployment, car accidents, mortality, injuries, impaired relationships, and possibly even substance use disorder. It was actually originally suggested that treatment of childhood ADHD prevented SUD in a meta-analysis that just included a few studies, but a subsequent meta-analysis that included more studies suggested that it neither increased nor decreased the risk of developing a future substance use disorder. So adult ADHD is actually very difficult to diagnose. In children, usually you have to get reports from teachers and parents in order to make the diagnosis. And we can't usually do that with adults. So there are checklists, but there's often a lot of false positives. What's a disorder, what's normal. And there are multiple causes of inattention besides ADHD, like other psychiatric disorders like substance use disorder, post-traumatic stress disorder, mood disorders, all are associated with impairments in concentration. And there also are lifestyle factors. Is the person getting enough sleep? Are they stressed out? These can all lead to problems with attention. There's no, like with most psychiatric disorders, there's no like diagnostic test or a lab you can get to diagnose the disease. So it really requires a comprehensive evaluation. And people with substance use disorders, they may be craving substances and feel convinced of the diagnosis and press hard. You might find that you get pressed hard for the treatment. It's also a popular diagnosis on social media, and people often are self-diagnosing themselves with ADHD. So one question is ADHD overdiagnosed? It's likely both over and underdiagnosed. I've certainly met patients where they had a clear history of, hyperactivity and attention difficulties and problems with school that were never treated, or maybe their parents didn't want them to get treated. There's a high degree of psychiatric symptom overlap with other psychiatric conditions, and that's a major cause of misdiagnosis. And there is clear evidence of overdiagnosis. There's been a broadening of the criteria for ADHD in the DSM-5. And there's actually evidence that the stimulants are less helpful in individuals with milder symptoms. There's also studies in school children that those who are entering kindergarten who are born earlier in the year, so their birthday falls before the cut date, so they're just turning 5. They are diagnosed and treated with greater frequency when those born later in the year. So children born after September 1st, or whatever the cutoff is in your state, is going to be, almost turning 6. Um, and exaggeration and malingering are well documented and can be effective, especially if doctors only use symptom scales alone without doing a more comprehensive evaluation. So DSM-5 broadened the diagnostic criteria to make it more applicable to adults. So previously, you had to have 6 symptoms of inattention, and that was changed to only 5 symptoms if you're an adult or an adolescent. They also changed the language so that, say, for example, fidgeting or not being able to get out of your seat or stay in your seat, that could be just impulsivity or fidgeting for adults. Previously, the symptoms had to be present before the age of 6 or 7, I believe, and they changed that to symptoms have to be present before 12. And also, the language changed such that it used to be that there had to be a clinically significant impairment in social or vocational life, and that was changed to reduce quality of social or vocational life. So really kind of making the bar lower to make a diagnosis, and this actually has been associated with higher rates of diagnosis of ADHD. So we're going to do a couple of case studies. We have Jeff, who's a 29-year-old man with opioid use disorder, who presents to your outpatient clinic and is on 16 milligrams of buprenorphine naloxone. Staff are reporting he frequently interrupts, can't sit still. He does say that he had a diagnosis of ADHD when he was 14, but his parents didn't want to do medications. He also reports that he had a successful trial of lisdexamfetamine, 70 milligrams, with another doctor, but she won't prescribe it anymore because I was using. He's not working. He lives with his girlfriend who works as a nurse, and they have a 3-year-old daughter. So often it might be a good idea to, when you're doing a diagnostic assessment, is to slow it down. Set expectations like at the beginning of the visit that you won't prescribe drugs at the first visit, just so they're not let down. Because you really want to do this carefully and thoughtfully. There are limitations in utility of the assessment tool, so it's probably a good idea to obtain collateral. It's probably not going to be a realistic route to get collateral from coworkers, but you could talk to parents, depending on their age or their partners or previous clinicians. And when I inherit a patient who's on stimulants, I always get releases to talk to people, including if they were prescribed it before. I want to talk to the previous prescriber, or to see if there was any issues, or why are they switching prescribers? Did that person decide to not prescribe it anymore for a specific reason? And also to closely look at comorbidities, as mentioned, many other conditions can present with problems with attention. So for Jeff, what would you want to do? You could either conduct a thorough assessment for ADHD, as well as other psychiatric comorbidities, get a urine drug screen, check the prescription drug monitoring program data, obtain collateral from his girlfriend and past prescriber, suggest some behavioral modifications, and consider starting him on a non-stimulant like guanfacine. Or you could do a quick screening tool on Jeff, in which he endorses all symptoms of ADHD and put him back on the list, dexamphetamine 70 milligrams, and tell him to come back in a month. So after a thorough assessment, he returns 2 weeks later, reporting that guanfacine has helped him sit still and feel calmer, although the inattention continues to fear with his program and his life at home. He stabilizes nicely in early recovery, as supported by good engagement in the intensive outpatient program. He's going to 12-step meetings. His relationships with his partner have improved, and he has several consecutive urine drug screens. You talk to his prior prescriber, who tells you things that are consistent with his report, indicating lisdexamfetamine was stopped after opioids were detected in the urine drug screen. He spoke with his partner, who reports frequent discord with Jeff when he fails to complete chores, has poor follow-through on commitments, and is frequently distracted during conversations. So you discuss the risks and benefits of stimulant treatment in the context of substance use disorders, and you decide together to restart lisdexamfetamine at a lower dose, 30 milligrams, which is the usual recommended starting dose. Now, if you went the other route and you just restarted back on 70 milligrams, he returns in a month and he reports the medication is working great, and you begin seeing him monthly. A few months later, he calls a week after his meds were refilled, stating that when he was opening the bottle, the rest of his capsules washed down the drain. You ask him to come in for a urine drug screen, and he can't get in for another week, and then he appears very guarded, withdrawn. And by the end of the visit, he shows you images on an infrared camera that he believes is proof that people have been hiding in the walls of his house, and perseverates on the FBI monitoring him, showing that he had an episode of psychosis. So what is the evidence base for pharmacological treatment? It's important to know that there's a lot of conflicts of interest. Many prominent researchers in ADHD receive funding by pharmaceutical companies. There was a Cochrane review on methylphenidate in 2016, which was retracted for undisclosed conflicts of interest. There was a Senate investigation in 2008 because of lack of disclosure of pharmaceutical funding by some prominent investigators as well. It's also some of the patient and family advocacy groups for ADHD receive funding from pharmaceutical companies. And most of the panel members responsible for widening the definition of ADHD and allowing the adult ADHD diagnosis have ties to industry. There's also, stimulants also stand out from other drugs in that there's been more marketing dollars devoted to practicing physicians compared to most other drugs. So 25% of all industry payments to pediatricians were for 3 stimulant medications. And in between 2014 to 2018, $7 billion were spent on marketing to physicians for lisdexamfetamine alone. That's a huge amount of money. So why treat adult ADHD? People subjectively feel better. They report reduction in mental health symptoms, improved attention, decreased impulsivity. There's been, they might have improvements in employment or work functioning, decreased accidents and injuries, and improvements in their relationships. And there might actually possibly reduce substance use disorder or support recovery. So what outcomes would you look to support treatment? It takes a long time to really see these outcomes. You can track how well they're doing with symptom scales, psychiatric interviews, like how well do they stay in care, what does their employment history look like? Do you see any improvements there? Are they less likely to get into driving car accidents? Or are they less likely to have hospitalizations or ER visits? And how are their relationships improving? So it takes a while to kind of see these outcomes. And also, is it affecting their substance use? So there was a Cochrane review on amphetamines for adults in 2018, which included 19 randomized controlled trials that included dextroamphetamine, lisdexamfetamine, which is a prodrug of dextroamphetamine, or the mixed salts. Most of them were funded by pharmaceutical companies, and they were short studies. The median length of the study was 5.3 weeks. The range was between 1 to 20 weeks, and they were all placebo-controlled, and only 3 included an active comparator, guanfacine, modafinil, or paroxetine. So the participants were mostly male, mostly Caucasian. A few studies did include people with substance use disorders, but most of them did not. And they reviewed outcomes such as severity of ADHD symptoms, retention and treatment, and adverse events. And they actually rated the quality of the results to be very low to low. And they had concerns about the internal validity of the studies because there was a lack of blinding. When you compare a stimulant to the placebo, the patients could feel subjectively which drug they were on. There was high rates of attrition. There were some studies that didn't actually pre-specify what their primary outcomes were. There were some crossover studies that didn't include a washout phase, and they were short duration, as mentioned. So the results showed that compared to placebo, the stimulants did have a significant reduction of severity of symptoms, and either in terms of ratings by clinicians or patients. There was patient ratings. Patients reported 30% reduction in ADHD symptoms, but there really was no differences for the active comparators. There was no differences for amphetamine versus guanfacine or amphetamine versus modafinil, but these were only a couple of studies and they were not very large studies, so they might have been underpowered to detect any differences. There was no effect on treatment retention, and there were actually increased withdrawals due to side effects within individuals that were randomized to the stimulant groups. Another Cochrane review that focused on methylphenidate, immediate release and extended release formulations. They had similar limitations, heavy industry influence, short duration of the studies, and high risk of bias. For the Oros formulation, there was no effect on mixed days of work at 13 weeks, and there were small to moderate effect sizes on self-rated ADHD symptoms. And there was one direct comparison study with lithium that found no difference in methylphenidate versus lithium, which is perplexing. So are stimulants more effective than the alternative drugs? There aren't that many studies that directly compare the drugs, and standard teachers about relative effects are based on indirect comparisons of effect sizes. There have been studies of network meta-analyses where they actually pull results from studies where they are comparing to stimulant to placebo, um, and they use the same body of evidence. And so there's one network analysis that was done in 2020 that showed no clinically significant differences between the medications, and they looked at stimulants as well as non-stimulants, atomoxetine and guanfacine and bupropion, as well as modafinil. Another study in 2018 found that amphetamines are better than atomoxetine and methylphenidate, and atomoxetine was similar to methylphenidate. And this is in terms of reducing ADHD symptoms. In some other literature, there have been a few head-to-head trials, but they're very small, 52 to 98 subjects. They really didn't find any difference between stimulants and non-stimulants. There was one study comparing amphetamines to paroxetine, and about 3 studies were comparing methylphenidate to atomoxetine. So functional outcomes in observational studies, not randomized studies, prescription stimulants are associated with decreased car accidents. So they will often use a design where they compare periods where individuals are taking their stimulants versus not taking them and find more car accidents when they're not taking their stimulants. There's also been decreased unemployment among women, but not men. A meta-analysis of randomized controlled trial data shows modest effects on short-term abstinence from cocaine use disorders, mostly attributed to individuals prescribed higher doses of amphetamines. In children, the effects of stimulants on behavior, the effects are more strong for behavior than actually on learning, as measured by GPA, neuropsych testing. But there's a much bigger effect on subjective drug liking. So in adolescence, the effects on liking the drug, which is an indicator of abuse potential, were much stronger than any improvements that were seen on neuropsych testing. So in the clinic, what ways can you assess functional outcomes? Does your patient have a job? What kind of feedback are they getting from their supervisors? Are they able to get to work on time, complete tasks on schedule? Are they making lots of mistakes? Home life, are they managing their responsibilities in terms of household chores, projects, appointments, parenting, picking up the kids on time, and other social factors like feedback from loved ones, like are you listening, are you interrupting constantly, emotional regulation. So another case, Edie is a 39-year-old woman with an opioid use disorder who's on buprenorphine, naloxone. Prior to treatment, she also used cocaine regularly, which she felt helped her, but she's been avoiding cocaine because she's on probation. So she presents asking about medications for ADHD. She has a history of childhood trauma, and for a period was treated with stimulants while she was a child. She's working full-time at a local grocery distributor and feels unfocused. Her sleep is impaired by nightmares that relate to past trauma, and she uses marijuana dabs to help with sleep and anxiety. So one approach to treatment is you can provide validation without medication. And really thinking about the foundation of recovery, like which part of the brain is in the driver's seat right now? Are the ADHD symptoms really what's impairing you, or do we really need to prioritize the ongoing substance use disorder as the focus right now? You can talk about behavioral strategies, making to-do lists, um, things to help with organizational strategies, and also set realistic expectations. This is not going to turn you into a person who doesn't have ADHD. It's just going to make you function a little bit better. And the goal isn't for you to feel something when you take these medications. You might want to consider a non-stimulant trial first, such as guanfacine or atomoxetine. Um, you probably want to use the extended release formulations, as they may have less abuse potential, or lisdexamfetamine, which is a prodrug. Um, and also, is the person using cannabis? I mean, there's been many studies showing that cannabis impairs cognitive function, and but you generally see improvements in cognitive function and working memory, especially like within like a month after they stop using, which could also be one of the reasons why they're complaining of problems that are consistent with ADHD symptoms. So for the case study, you can either tell Edie that because of her prior cocaine use, you're concerned about her increased risk with this potentially addictive medication, and you're not going to prescribe stimulants. Or you can advise Edie that marijuana and post-traumatic stress disorder are likely to be significantly contributing to her symptoms, and prioritize those issues to target first before thinking about stimulants. So if option one, you tell her that you're not going to prescribe it because of her cocaine use, she gets angry. She accuses you of not wanting to help her because of her past, and she storms out of the evaluation. She later apologizes and insightfully reports her reaction was reminiscent of emotions she experienced during past traumatic experiences with authority figures. And she continues on in treatment. She maintains her abstinence over the next year, though her cannabis use increases, and at several points tests positive for illicit amphetamines and cocaine. The other option is you advise Edie that marijuana and PTSD are likely to be significantly contributing to her symptoms. So she stops using cannabis, starts individual therapy. You increase her prazosin to 5 milligrams to improve her sleep, and it does. She does feel she gets distracted at work, but continues to hold her job, and her supervisor gives her a positive rating. She's a great worker. She still thinks the stimulant may help her, but understands that this may also be a form of craving. And as time goes on and her feet are more firmly rooted in her recovery, she notes improvements in her functioning and clarity of mind without cannabis, and concludes that a stimulant trial isn't worth the risk. Now, next we're going to switch on to the potential harms of stimulants. What are the risks? There's a risk of the person becoming addicted to the stimulant. There's risk of diversion, psychosis and mania, cardiovascular outcomes. Stimulants increase blood pressure, and that can have consequent downstream adverse outcomes. It can affect sleep. In kids, there's growth suppression, appetite suppression, tics. And so, again, it takes a long time for you to really assess these outcomes. There's toxicology. You can do urine drug screens, look at med diversion monitoring outcomes, check the PDMP counts, pill counts, toxicology testing. Is the patient having visits to the ER and psychiatric hospitalizations? Are they having increases in their blood pressure, heart rate, and do they have any adverse cardiovascular outcomes? Are they losing weight? So just wanted to mention briefly the quality of the data on the harms that led to FDA approval of stimulants. So the general recommendations are that there should be short-term studies with at least 300 to 600 patients for 6 months or more. And according to the International Conference on Harmonization of Technical Requirements for Registration of Pharmaceuticals, and they usually only require 100 patients for 1 year to look at common long-term safety data. So just to compare, for fluticasone, which is another medication that's chronically treated for a condition, they had 1,090 patients treated for 3 to 4 months before approval, and there was more than 500 patients in a 12-month safety study. Now, out of the 20 stimulant drugs, there was a median of 70 patients for each of the drugs, and the median duration of treatment was 4 weeks, leading to registration. And 11 of these drugs were actually approved with less than 100 patients, and 5 drugs were approved with less than 4 weeks of data on efficacy. So we're really we're approving drugs with very small numbers of patients and short studies. And the required data of 100 patients for a year was actually available for 6 drugs, but only 2 of the 6 required studies were actually performed. And in May 2023, just last year, the FDA updated their box warning to kind of raise more concerns about the risk of misuse and addiction to prescription stimulants. Previously, they talked about abuse being a potential for abuse and dependence. And they updated that to make it more clear that abuse, misuse, and addiction can lead to development of substance use disorder, including addiction to the stimulant itself. Previously, they recommended assessing risk of abuse prior to and while prescribing. And they kind of expanded this to educate patients and their families on their risks, proper storage, proper disposal, because they were concerned about diversion, reassess each patient's risk of abuse, misuse, and addiction, and frequently monitor for signs or symptoms of these symptoms. They also focused on other risks, saying that misuse and abuse can result in overdose and death, and this is increased with higher doses or unapproved methods of administration, such as snorting or injection. So much stronger language. And this was based on, some concerning data that they were seeing and a review of the literature going up to May of 2020, before the big acceleration in stimulant prescribing. Now, in the quality of data on harms, I'm going to mention that network meta-analysis published by Cortese again, which is likely to affect policy. They take into account both efficacy and safety. The evidence suggested that amphetamines in adults, as preferred as their first choice medication, as saying that amphetamines are better than methylphenidate and amoxicillin, etc. Now, one thing to realize is they excluded studies with high doses. So if they were patients who were on 40 milligrams of mixed amphetamine salts, those studies were not included. The studies were very short, like the studies for amphetamines were less than 5 weeks long on average. They did not highlight that these studies excluded people with previous psychosis, hypertension, or tics. And they measured safety by tolerability, which they defined as withdrawal from the RCT due to side effects. And there was many editorials published right after this paper was published, criticizing that they didn't address important adverse events, common adverse events like sleep disturbance, headache, loss of appetite. Both the paper and the editorials completely ignored the risk of abuse or substance use. And there was a lack of attention to substance abuse disorder risk. And it kind of reminds you a little bit of opioids and the era of marketing about opioids and chronic pain, where they really kind of were telling people that opioids weren't addictive in people who had chronic pain, which is obviously not the case. My own research has focused on the risk of psychosis and mania in new onset in people who are prescribed stimulants. So in the first study, this was a cohort study where we basically looked at new users of amphetamines versus methylphenidate in between the ages of 13 to 25, and found that the number of patients is on the left y-axis, the number of psychotic episodes is on the right y-axis. And you can see that the rates of psychosis were much higher in the amphetamine group, even when we matched on in analyses where we matched, so there was a similar number of patients with similar confounders, and that the psychotic events closely matched tracks the prescribing of amphetamines. In another study using electronic health records that is currently under revision, we looked at a case control study where cases were individuals presenting with first episode psychosis or mania, and controls were patients presenting with other psychiatric disorders, and found that individuals who were prescribed high doses had more than a 5-fold increase risk of psychosis or mania. So the high dose was defined as 30 milligrams. We converted all the drugs into dextroamphetamine equivalents. So this is about similar to 40 milligrams of the mixed salts. And as you recall, these are the studies that are being not included in these network meta-analyses. So I think this is important to note that the risks are much higher on these high doses, which are actually pretty commonly prescribed. Um, Cardiovascular risk, stimulants increase blood pressure and heart rate. In observational studies, they've found that non-elderly adults below the age of 64 don't have an increase in serious cardiovascular events, but older adults greater than 65 did have an increased risk of serious cardiovascular events such as ventricular arrhythmias, strokes. And it's one thing to consider that these events happen shortly after initiating within the first 30 days, but also you have to take into account that, well, in real world practice, your individuals are less likely to prescribe drugs to individuals with pre-existing cardiovascular disease, so it might actually underestimate the effects on cardiovascular risks. There's also one interesting study by Westover that found that off-label prescribing of adults is rising, and it was associated with increased all-cause mortality compared to patients who were with on-label prescribing, for example, for ADHD or narcolepsy. And this was a study looking at medical records, so it was really unclear what are the reasons for the off-label prescribing, but the patients did have a lot of comorbid psychiatric conditions. Another observational study suggested a potential benefit on overdose. Among people on buprenorphine for opioid use disorders, the individuals who were prescribed stimulant therapy had a 19% increased chance of non-fatal overdose, but a 36% increase in treatment or retention. So the authors concluded the risk benefit was that the benefits of staying on buprenorphine outweighed the risks of the overdose. One thing, a caveat about this study was that they only included people with high adherence to stimulants. So it's not surprising that if you have a high adherence to stimulants, you're going to have high adherence to buprenorphine. So it's one thing to take into mind. And just to kind of go back to some of the similarities between stimulants and opioids, there was if you look on this paper to the right, there was a huge number of citations of this letter to the editor that was published in the New England Journal of Medicine. And this was used as the evidence that people treated with opioids for pain were not developed addiction. I've read many of these papers, and that would literally be the only article that was cited that supports using opioids for pain, like chronic low back pain, for example, wasn't an addiction risk, which we obviously found out was not true. And this was like a brief paragraph where they basically looked at hospitalized patients who got at least one prescription for opioids and found they only had 4 cases of reasonably well documented. So to extrapolate, somebody having surgery and getting an opioid, or some opioid for some pain condition in the hospital to safety for chronic low back pain based on, a paragraph with no description of the methods or analyses is kind of really striking. And some other parallels with the opioid crisis, we see an expansion of the target population. Opioids were previously used for cancer pain. Now they're being used for chronic pain of all types. The evidence for treatment was heavily influenced by pharma and based on subjective outcomes like pain scores or ADHD symptoms. Important safety encounters, including the risk of developing addiction to the drug, was really kind of minimized. We saw rapid rises in prescribing of both opioids and stimulants. The company that originally approved lisdexamfetamine, Shire, actually was fined by the FDA for misleading advertising where they were saying it was less addictive than other stimulants, even though they had no evidence supporting that. And doses and then we're using higher doses than that are really without like much evidence that those doses work better or are safe or don't have major safety risks. And we're also seeing an increase in stimulant related deaths. Although, so far it seems that most of these stimulant deaths are due to methamphetamine and cocaine, and very few, less than 5%, involve prescription stimulants. But it is possible, just like the use of opioids often led to people transitioning to heroin, it's unclear if it's possible that some patients who are prescribed stimulants might be transitioning to other stimulants like cocaine or methamphetamine. So the key takeaways from this talk is that adult ADHD does carry significant comorbidity and morbidity. There's a higher prevalence among people with substance use disorders. Diagnosing ADHD is complex and time consuming. The evidence base for the benefits of treatment consists of multiple studies that were deemed to be low quality and often don't include functional outcomes that are really important to patients. The risks of non-stimulants are fewer, and although they might not be as effective, possibly, they could be comparable to stimulants in terms of functional impact. And when you treat, I think prescribers often go directly to stimulants. When you treat pain, you start off with like Tylenol or an NSAID, and then you progress, and then maybe you prescribe a COX-2 inhibitor, and then you go to opioids if that doesn't work. So, I mean, I don't think doctors are considering the possibility of doing that. Like, start with a non-stimulant. If that doesn't work, then try methylphenidate. If that doesn't work, then go to the amphetamines. And there are major risks to stimulants, including misuse, developing of abuse of the stimulants, cardiovascular events, and rare events like cardiovascular serious outcomes and psychosis. So I guess that leaves plenty of time for questions, comments. So interested to hear what everyone, if you have any questions or discussions.
Thank you so much. I'm not getting any questions. I am getting a ton of praise from Dr. Karp. Phenomenal lecture. Thank you. Excellent talk. Thank you. So I'm definitely getting some praise. Thank you again for coming and speaking with us. Anybody want to unmute their mics and participate? Another great lecture. Yeah.
Do you ever require that patients stop using marijuana before you'll prescribe a stimulant? I mean, it's so obvious that that's frequently contributing to the problems with memory and concentration. And so many of our patients that we prescribe, both non-stimulants and stimulants, are using marijuana. What's your approach?
Yeah, I mean, I think it's important to just educate the patient about that. I think a lot of patients don't realize that marijuana can cause cognitive problems. And it might be a good idea to, suggest that they stop using and also just get a sense of how often they're using. If there's somebody who uses once in a while, it's not a big deal. But if they're like a daily user, I think the most important thing is for them to stop using the marijuana first before you add another addictive substance onto the mix.
Thank you.
There are scales. There's a question that comes up for kids. There are some rating scales that are sent to parents in schools. There are some rating scales for adult ADHD that you could send to family and even to work if the patient's okay with that for adult ADHD. I think that's kind of the problem with the difficulty of diagnosing adult ADHD is that sometimes I've seen prescribers like say, well, why don't we give this to your parents so they can actually assess if you had these symptoms during childhood, but there might be some recall bias in that. And I think a lot of patients might feel uncomfortable with you sending scales like that to their work. Family, sure, yeah.
When I have a patient with comorbid anxiety, often my first line is to choose atomoxetine because
Yeah,
it
because the
helps
stimulus can work.
clarify if the anxiety is really driving the problems with inattention.
Yeah. And I've actually seen people misdiagnosed with ADHD when it was clear that they had anxiety. And those patients were more likely to have like some adverse outcomes, side effects. Yeah. Mhm.
Great. Well, thank you, everyone. And one last final pitch. If you need CME credit, please text 44019 to phone number 1-866-327-3062. Steve has dropped that in the chat quite a few times. And our next lecture will be in April, on April 4th.
Okay, thank you
Thank
so
you
much.
again, Dr. Moran. It was so wonderful having, and then we got up to like 48 people, and I know that this is always a topic of hot debate. So
Thanks so much.
Thank you very much.
Thank you. That was great.
thank you.